Thank you for slight delay. Dr. LEELA is just arriving, so I start the session first so that we will be quite on time when it comes to today's session. So, good morning, Assalamualaikum, and welcome to all of you. And today, Clinical Pathology Conference, we're from the Department of Pediatrics. So this is very much a valued space within the faculty where all of us actually pause from our clinical works to kind of reflect and reason out and refine our real case scenarios. And today's session is actually titled The Saga of a Sinking Count, but as Dr. Rizwan will reveal to you, this is a case of an 11-year-old girl with a pancytopenia. This case, we hope it promises some sort of a puzzling black trends where you all can look at the clinical journeys, where you can looking at the layering of questions, some of the subtle signs, and hopefully a diagnostic turn that will keep us all thinking. More importantly, especially when it comes to CPCs from Department of Pediatric, this session is not a presentation or a performance by Department of Pediatric. It is a shared learning experience and space for all of you, particularly students. And I would like to emphasize everyone in the room, students, members of the faculty, trainees, you are expected to think aloud, challenge your assumptions, and test your own clinical reasoning as we go on. And as I believe there are only 3 people in the room that knows what the case is, and definitely not Dr. Rizwan. So we are fortunate to have 3 excellent colleagues of mine who will be guiding and anchoring the discussion today. As you can see, the names is on the screen. So to begin the session, we have Dr. Rizwan. Dr. Rizwan is our pediatric registrar who's going to be stepping into the case with only the summary that you all actually receive. So like many of you, he will be seeing the clinical clues unfold in real times. You know, the information that he have is similar to all of you. And he is expected to think clinically, adapt, and eventually arrive at the working diagnosis based on what is being revealed during the session. So he's here not just to present, but to model to especially the medical student, the diagnostic reasoning that we all go through when faced with uncertainty at the bedside. And then once we heard from Dr. Rizwan initial impression, then I will call Dr. LEELA DEVI, who is our pediatrician and a fellow in pediatric gastroenterology. She is very key to the today's presentation because she will take us deeper into the clinical context. She will reveal the investigation and what happened to the case. And Dr. LEELA also will eventually summarize and connect the dots and provide some of the learning outcome for this case. And together, during this session, we also have Dr. AZLIN from the Department of Pathology who will provide the essential insight into the laboratory and the pathology aspect of the case. She will reveal some of the expert invaluable information in this case to be unveiled when it comes to the diagnosis. So that's what the session will happen today eventually. And I would like to invite you all to sit up. Of course, stay curious, start thinking, have your clinical reasoning, and with that, let's dive into today's case, the saga of the sinking count, and I would like to invite Dr. Rizwan to share his thoughts on the case.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all professors, lecturers, and members of the hall. I'm Muhammad Rizwan bin Esmom, the postgraduate trainee pediatric, where we present regarding clinical pathological conference for Department of Pediatrics, the title of the saga of the sinking count. I would like to recap the case I've been given previously. As seen, 11 years, 6-month-old girl presented with short history of fever for 2 days, suspected with lethargy for 1 week. The fever was actually intermittent and high grade, with loss of appetite and poor intake. However, in this period of time, there's no significant weight loss, and then the other thing is mild dry cough with no rhinorrhea or no dyspnea. On the other side of negative 11 symptoms, There is no headache, night sweats, neck stiffness, photophobia, or rashes may represent as no significant neurological infection symptoms. The normal bowel opening, just once per day, Bristol type 2-4 with no vomiting or abdominal pain may indicate some non-GI involvements. For the birth history, it's actually much more unremarkable. Birth and natal history was unremarkable. Born term with vacuum assisted delivery with birth weight 2.5 kilo with no natal issue anternatally and postnatally. The 6PD was normal. For the family background, she is the product of consanguineous marriage. Both of the parents are first cousins. This may have a higher possibility of recessive gene inheritance. Mother is 37 years old housewife, the father 37 years old contractor. With the other two younger siblings, both of them are healthy. She was immunized up to the age with no other additional vaccinations and attend primary school, very good in academic performance and social skill. However, other things is diet history. She is the picky eater and takes small portion of the meals. May arise to some issue with the nutritional deficiency. She consumes rice, vegetables, and prawns, but dislikes chicken and fish. It may come to our thinking about protein deficiency disease, and then, however, she's still taking full cream milk once per day. At the presentations in emergency department, she had moderate grade fever with temperature of 39 degrees Celsius, proportionate tachycardia due to the fever at 160 beats per minute, respiratory rate borderline tachypnea about 30 breaths per minute with blood pressure still normal with the oxygen saturation 100% under room air. Her weight is plotted below SD2 negative at 25 kilo, and he is presented with the lethargic, pale and jaundice with cold peripheries and reduced pulse volume. This is the evidence of impaired circulations with the liver involvements. However, she is not in the respiratory distress or no rashes. Her mucous membrane is still moist, which indicate still normal hydrations. The angular stomatitis with glossitis will give rise of vitamin B deficiency. However, the throat, lung, cardiovascular, abdomen, and all others is actually not significant. In the blood investigations, shows that normochromic normocytic pancytopenia with the evidence of MCV and MCH still in normal range. However, RDW, the red blood cell distribution width was raised until up to 21%, which basically a normal about 11 to 14%. The total white and also the platelets also low for this patient. Liver function test was significantly raised for the transaminitis. The AST more than ALT, which indicates some indications for the liver problems. One of the problems is liver cirrhosis, which can be inherited or genetic, can be inherited by hereditary atresia or genetic from the Wilson disease or alpha-1 antitrypsin. Other than that, liver function test is basically normal. Other than transaminitis, other indicator is normal. Renal profile is normal. However, LDH is much raised to indicate some tissue or cell destruction or damage. C-reactive protein mildly raised, 1.87 milligram per deciliter. It may indicate that there's not much of the serious infections. To recap, for summary, this patient, SC, an 11-year-old girl, was previously well, presented with a fever, lethargy, jaundice, pancytopenia, transaminitis, and high LDH. She is the product of consanguineous marriage and small for age. With that elements that have been given to me, I have come about 7 differential diagnoses. The 7 diagnoses is viral hepatitis with bone marrow suppressions due to the infections, EBV, CMV, or hepatitis. The hemophagocytic lymphohistiocytosis, HLH, acute leukemia, aplastic crisis, parvovirus B19, which also can cause fifth disease, nutritional deficiency, vitamin B12, folate deficiency, autoimmune hepatitis or systemic lupus erythematosus SLE. Last but not least is sepsis with multi-organ involvements. For the viral hepatitis with bone marrow suppressions due to infections, the supporting evidence is actually fever and jaundice for this patient, come with a high AST and ALT, prevalent is AST, with mildly raised bilirubin. The viral marrow suppressions can cause pancytopenia and LDH, high LDH due to might come from the hepatocellular damage. However, this patient not come with any abdominal symptoms. There's no nausea or vomiting, and no any other symptoms that may arise from the liver problems. For the further test, is actually I will discuss later. For hemophagocytic lymphohistiocytosis, supporting evidence is fever. However, the fever is not high grade. It's not high grade fever at more than 38.5. Having pancytopenia, hepatocellular injury, and very high LDH. The familial HDH is raised the suspicion of familial HDH because of the consanguinity. However, there's no hepatosplenomegaly, but it can be at the early presentation, which the hepatosplenomegaly not yet happened. The against for this HLH is actually no prolonged fever. Usually come with a prolonged fever more than 7 days, and no splenomegaly. For the test, I will discuss later. The acute leukemia, the supporting is actually fatigue, lethargy, poor appetite, pancytopenia, high RDW, and high LDH from cell turnover. The against is no hepatosplenomegaly, no lymph nodes, no bone pain, PTK, or any bleeding tendency. The aplastic crisis, fifth disease, due to parvovirus B19 infections. It can come with sudden drop in HB, pancytopenia with normal MCV. However, this patient don't know regarding any chronic hemolytic anemia, which is sickle cell disease or hereditary spherocytosis. Usually, it's not associated with the high transaminases. For the nutritional deficiency, as a patient is picky eater and take low animal protein intake and presented with glossitis and angular stomatitis with pancytopenia and high RDW. But against the MCV is normal, which the B12 deficiency come with a macrocytic anemia, does not and also does not explain why they have been high transaminases and jaundice. For the autoimmune hepatitis or systemic lupus erythematosus, supportive is actually this child is female, age appropriate, which is the SLE come mean presentation at 10 to 11 years old. Cytopenias and transaminases may indicate the autoimmune disease, but there's no any classical CLE features such as joint pain, rash, and joint swelling. There's no family history for SLE. Last, the sepsis with multi-organ involvement. Patient come with this acute onset of fever, tachycardia, pancytopenia, but the CRP is not markedly elevated to see for the sepsis. But there's no any significant source of infections. There's a mild URTI symptoms.
Okay, Rizwan. So this is the list of your differential diagnosis based on the case and the information that we provided to you. So what will be the further histories or information that you want to acquire more about this case based on the list of differentials that you have?
Okay. For the further history, I would like to...
Okay, for this, maybe I will directly invite Dr. LEELA to kind of communicate with you with some of the findings so you can have a thinking process along the way at the same time.
Sure.
Yep.
For the further history, I would like to dig further regarding duration and pattern of the fever, because I need to know this is any issue with the prolonged fever, and then any viral infections that can cause the evening rise fever, and then chills and rigor, which is may indicate some bacterial infections.
Okay, so duration of fever, as we stated earlier, is 2 days. Is daily intermittent high-grade fever. No evening spikes, no chills or rigors.
Okay, thank you, Dr. LEELA. For the recent sick contact or any exposure of the viral illnesses?
No ill contact.
For the travel history, for endemic regions, any for the hepatitis and malaria?
No recent travel as well.
Okay. For the family history, if any family history that's suggestive, any genetic problems for the hematology disorder or autoimmune disorder?
So there is a significant family history in the maternal aunt. So the maternal aunt, which is the parent's first cousin, has congenital megaloblastic anemia with iron deficiency anemia, folate and vitamin B12 deficiency on 3-monthly vitamin B12 injection. And this aunt was also a product of consanguineous marriage.
Thank you, Dr. Leela. Any sign of bleeding tendency or neurological symptoms that may come?
No bleeding tendencies, no neurological symptoms.
Any past medical history for this particular child?
No past medical history.
Okay. Can I get further history for the diet history?
Okay, so the diet history, this child was breastfed until 2 months old, exclusively, and then subsequently started on formula milk. At 6 months old, started on complementary feeding. And then subsequently, the child was a picky eater, eating small portions as mentioned. She would eat rice, vegetables, but she would take egg. She dislikes chicken and fish, but she will take some seafood. And as mentioned before, she takes full cream milk once a day.
Any multivitamins taken over the counter?
No medication or toxin exposure.
Yeah. I think I go to the further examinations. I would like to see for any skin involvement, to see the for bleeding tendency or.
So skin-wise, she was pale, but otherwise no other skin rashes.
Okay. Any mucosa involvement such as ulcers, gum bleeding?
No oral ulcers or gum bleeding.
Okay. Any liver or spleen?
On re-examination, still no hepatosplenomegaly.
Okay. Any lymph nodes that may be subtle?
No subtle lymphadenopathy.
Any neurological signs that may come after the?
No neurological signs as well.
Any musculoskeletal that can come afterwards?
No musculoskeletal findings.
Can I get the further regarding growth parameters for the child?
Sure. The height is 136 centimeters, lies at the 3rd to 10th centile. BMI is 13.5, which is below the 5th centile.
Thank you, Dr. Leela.
So with the information that you have, do you like to revisit your differential diagnosis? Is there any change, or do you like to prioritize some against the others, or you would like to suggest might be a few other differentials?
Yeah. For this child, because of the product of consanguineous come with the congenital megaloblastic anemia with folate deficiency. This child also have that risk of to getting the same presentation as the auntie. I think the differential diagnosis that come across is nutritional deficiency, vitamin B12 folate deficiency might come to the high suspicious for now. Other than that, it's actually we can the viral infections and also the hepatitis can come lower to the differential diagnosis.
Your second or third differential diagnosis will be?
The second diagnosis is actually because of the involvement of the liver. There's still I need to rule out regarding the autoimmune of the hepatitis, autoimmune hepatitis.
Okay. So is there any list of investigations that you liked from us, from
Sure.
Dr. LEELA? Yeah.
Okay. For the further investigation, I would like to have the peripheral blood film to confirm regarding the abnormality of the red blood cell, white blood cell, and also the platelets, and also any abnormality cells that can be seen from the peripheral blood film. For the reticulocyte count, I would like to see for the marrow response regarding the anemia, and then is it appropriate or not appropriate. The viral serologist is I need to know regarding all the viral serologists that may come with the patient come with hepatitis with the high transaminases. That one of the most common is because of the viral infections. Ferritin, triglyceride, fibrinogen, and soluble CD25. It's a must for to exclude the diagnosis of hematophagocytosis. B12 and folate, to see for the evidence of B12 and B9 deficiency. Bone marrow aspiration and biopsy to see for the hematological disorder or dyskeriosis and may exclude the malignancy. ANA, double-stranded DNA, LKM1. NA, double-stranded DNA is a hallmark for the SLE. LKM1 is a hallmark to see the association between autoimmune type 2 in correlation to the SLE. Blood culture is just exit analysis to see for any sign, any site of infections for this patient as come with the sign of symptom of infections.
Okay, with that further investigation, the first on the list is your peripheral blood film. With that, I would like to call Dr. AZLIN from Department of Pathology. You stay up there, reside at the side, to show you the peripheral blood films. And yes, just in case you need to ask anything.
Okay, Dr. Rizwan. So the case given is an 11-year-old girl presented with fever, lethargy, loss of weight and loss of appetite. And the full blood count showed pancytopenia. So I agreed with you with your list of differential diagnosis, which is about similar to mine. So can morphology help in this case? What's important to look for in a full blood picture in pancytopenia patients are these cells. So we're always worried about these cells. Do you think you know what these cells are, Dr. Rizwan? They are large. The nucleus looks hazy. These are some others, and these two. These are abnormal lymphocytes. Yes, they are abnormal, and they are actually blast cells. So these are the main diagnoses that usually we usually worry about. Okay, and this one here are lymphoblasts. Because the cytoplasm are smaller, less cytoplasm, higher NC ratio, and these ones here are more of myeloblasts or the granulocytic series because they have granules in their cytoplasm and they also have aurods and they have a nucleoli within their nucleus. Okay, so the other thing that we worry about are these cells. Okay, so this is like the one before. This is a blast, and do you know what this is? It's small as all these cells. This is actually a nucleated red cell, okay? So this is what we call a leukoerythroblastic picture, and it signifies that there is something going on in the marrow. So what this patient's peripheral blood smear looked like was this, okay? Actually, what we see are very hypochromic red cells. They do not look normochromic, normocytic as what the full blood count says, okay? So I will elaborate further on the cells, and there is also one peculiar white cell here, okay? So this is what actually a normochromic, normocytic red cell should look like, round and fluffy. And this one looks very thin and fragile, okay? So it's different. So when we have a microcytic picture, there are certain diagnoses that we want to look for, but morphologically common ones include this, okay? Those with hypochromic microcytic with a lot of target cells. But when you look at the full blood count, usually the MCV and MCH is low. And this you usually can correlate with thalassemia patients. And also we have hypochromic microcytic cells with some target cells, but there are also some elliptocytes present. Again, the hypochromic, the picture of the full blood count will show low MCV and low MCH, okay, which is not actually in this patient. And this shows more of a iron deficiency picture. And in both pictures, the RDW is also high. Okay. So we reported this patient with having severe anemia. We can see that the red cells are not close to each other. And the full blood picture, the full blood count shows normochromic normocytic, but actually it is hypochromic microcytic with a lot of anisopoikilocytosis, which just means that there are a variety of size and shapes of cells, okay? So you see target cells, the ones which are rounded with dots in the middle, and we see elliptocytes, We also see some schistocytes and teardrop cells. So this is not really typical of those two other presentations that I showed before. But fortunately, there were no blast cells and there's no nucleated red cells as well. Okay, but there was leukopenia with neutropenia, some reactive lymphocytes, some hypersegmented neutrophils. So I'll be showing a few more of these cells. No blasts and low platelets. Okay, so what are hypersegmented neutrophils? These are the ones. How do you know a hypersegmented neutrophil is a hypersegmented one? Do you know? Yes, okay, so the neutrophils will show more than 5 nuclear lobes. Okay, so this is a lot. Usually neutrophil will be 3 or 4 lobes. Another one with many lobes is eosinophils, but that will be more granular. So we look for, when we see these hypersegmented neutrophils, so we'll be looking for what type of red cells? We want to look for this type of red cells, which are rounded and a bit bigger than others. So we call this macrocytes. And when we have macrocytes, we want to think of this list of differential diagnoses: vitamin B12, folate, liver, hypothyroidism, so on and so forth. Okay, so at this time, because of this discordant type of morphology, our impression is severe normochromic normocytic anemia to rule out mixed nutritional deficiency, white cell changes suggestive of infection and inflammation, and true thrombocytopenia that we don't know the cause yet.
Okay, thank you, Dr.
Okay, I think that will be helpful for you, hopefully, Dr. Rizwan. With that, for the other list of investigation, thank you, Dr. AZLIN, for elucidating us in terms of the full blood picture. I would like Dr. LEELA to further elucidate some of the information that you want. And you stay here, Dr. Rizwan, as Dr. LEELA reveals some of the investigation. I would like you to think and provide your thoughts. Guna the mic.
Okay. So good morning, everyone. So I will continue from here on our case. So further history, dietary history I had already given, as well as the family history as you had asked for it. So these were the investigations given to you initially, as you have already gone through. I'd just like to ask you, from this, is there anything else you would want to know about the bilirubin?
Direct and indirect bilirubin, to see for the...
What? To see what?
Yeah, any direct bilirubin, it's actually associated with the more anatomical problems in the liver that can cause recirculation of bilirubin. The indirect bilirubin means the synthesis of bilirubin is actually impaired because of the infections, or yeah, I need to do on the bilirubin in the direct and indirect bilirubin.
Okay. So, so these are the further investigations, some of which you asked for, some which you didn't ask for, but was done for these patients. So I've just given it here. So direct bilirubin is actually given there, and some of the other investigations. So would you like to go through the results and try to synthesize it for us?
There is actually direct hyperbilirubinemia because of the 13.6 divided by 51 point. Yeah, it's more than slightly more than 25%. And the rating is actually not raised, as per suggested, should be raised more than 5% to respond for the anemia. LDH is have been talked before, it's actually raised. B12 is very low with the normal folate B9. Iron profile very low, iron with the high with the very low transferrin saturations. High ferritin level, it may indicate some HLH or any other than that. Triglycerides, can I know it's elevated, right? One triglyceride 1.04.
Actually not elevated.
The virus screens is non-reactive, blood culture and urine is no growth. Ultrasound, mild hepatomegaly with no fatty liver changes. From this further investigation that I can see, that the positive findings is B12 deficiency causing the anemia, but this anemia is just monochromic thrombocytic anemia with the underlying iron deficiency anemia that can cause the mixed picture of the normochromic and also macrocytic mixed picture of anemia. The retics shows low, that means some mild marrow involvements, the suppressions of marrow with the increase of direct bilirubin may cause, may suggest that high turnover from the hemolysis. And yeah.
So in hemolysis, would you get raised direct or indirect bilirubin?
Indirect bilirubin, basically, but yeah, from the ultrasound HBS, no suggestive of any structural abnormality, but yeah, the direct bilirubin.
Okay, so maybe just to help you here, because I know a lot of times we take the percentage. So, but now the thinking is more looking at the direct, at the absolute component. So usually we would take direct or conjugated hyperbilirubinemia to be more than 17 millimole per kilo absolute, rather than looking at the percentage. Yeah. So
it's still normal.
So yes, so this is unconjugated hyperbilirubinemia. Okay. So is there any way you can sort of put it together?
Okay. Unconjugated hyperbilirubinemia with the mixed anemia is causing by the vitamin B12 and iron deficiency anemia with the risk, and then
Do you think there's hemolysis going on?
If you see for the ratings, it's actually very low to see for the anemia response to the hemolysis. But Coombs test is negative, may show that there's no significant hemolysis.
Okay, all right. Okay, so I'll move on from here. Yeah. So this was already given by Dr. AZLIN early on. So the full blood picture does not show any intravascular hemolysis. But I agree that biochemically there is some evidence of hemolysis with the high LDH as well as unconjugated hyperbilirubinemia, which sometimes you might see if there is intramedullary hemolysis going on. Okay. So any thoughts on what your working diagnosis might be with all this additional information?
My working diagnosis for now is actually the mixed iron and B12 deficiency causing mixed picture of mixed anemia, called pancytopenia, with involvement of the liver in view of hemolysis, evidenced by high LDH and unconjugated hyperbilirubinemia. And clinical symptoms of with the presented with clinical symptom, which is the jaundice.
Okay, so your first one is vitamin B12 and iron deficiency. And the second one was, and the second part to it, you were talking about The liver?
The liver involvements, the unconjugated hyperbilirubinemia, it may come from the hemolysis, but it also can come from the autoimmune hepatitis because of all this viral panels is actually negative.
Okay. Yeah. Okay, so just to help you a little bit, anything that usually affects the liver hepatitis will give you more conjugated hyperbilirubinemia rather than unconjugated. So this one we would say probably unconjugated hyperbilirubinemia, but with some evidence of transaminitis. Yeah. Would that help you a little bit? But all the viral serologies were negative and cultures were all negative. Yeah.
The hemolysis causing the unconjugated hyperbilirubinemia and causing the transaminitis. The mixed B12 and also iron deficiency causing marrow suppression, pancytopenia.
Okay, good. All right. So you are actually very close to what the actual diagnosis is. So there was definitely symptomatic anemia because of the severe anemia, probably just triggered by intercurrent illness. So the child came in with fever, and the hepatitis was probably from just some intercurrent illness. But because of that increased metabolic or that demand, she went into a compensated shock-like presentation and with the transaminitis as well. So the severe anemia itself, as you rightly pointed out, is likely secondary to dual nutritional deficiency. So there was vitamin B12 deficiency as well as iron deficiency anemia. And the pancytopenia was secondary to the vitamin B12 deficiency. So you got that one right, yeah? So now that you have this working diagnosis, are there any further investigations you might want to do or consider at this point? Just based on this
to confirm with the B12 deficiency, the other things is we can see the metal malononic acid level. It will raise if there's B12 deficiency anemia. And then other than that, we need to see bone marrow if there's no any involvement of the any blood dyskeriosis or there is no any risk suspicion of malignancy, blood malignancy.
Okay. So that's fine. I mean, the metamalonic acid would be raised, but I suppose if you have vitamin B12 levels that were normal or borderline, that might be helpful. But we clearly have a deficient vitamin B12 levels here, so I think it may not be needed. But you may want to know what is the cause of the vitamin B12 and iron deficiency, right? What do you think is the cause?
The intrinsic factor that can cause one of the causes is actually this child is picky eater, then the reduce of intake of the vitamin B12 and also iron can cause the severe deficiency. And this child also product of consanguineness is some genetic predisposed that may predispose for the vitamin B12 and iron intake in the system to the GI system.
Okay, that's good. Any other causes you know that can cause either of these deficiencies? Okay, that's okay, but you've nailed some of the causes. So you want to think about poor intake, and then malabsorption, any losses, and then genetic causes, as you mentioned, as well as autoimmune causes. So losses-wise, we know that this child didn't have any diarrhea, right? Malabsorption is possible. Genetic and autoimmune is possible. Poor intake-wise, yes, she was a picky eater, but if you remember her dietary history, she did have some of these foods which contain vitamin B12, such as eggs and milk. Yeah, so for her to have such severe vitamin B12 deficiency, causing pancytopenia is less likely, especially because the liver stores for vitamin B12 is actually very good. Yeah, so that makes it less likely. So we want to think about more of the other causes. So any test you might want to send at this point. Can you think of any test you might think of if you're thinking more of autoimmune causes?
To see for the
okay, that's okay. We'll just take it from here. So anti-parietal cell antibodies and anti-intrinsic factor antibodies. Okay. Do you know what the intrinsic factor is for?
this factor for vitamin B12 to be absorbed in the gut GI system, which is the ileum.
Which part do you know?
Distal ileum.
Okay, close enough. The terminal ileum, yeah. And of course, as you mentioned, we should consider genetic testing because of the strong family history. Okay, so go on to the progress of these patients. This patient, or you want to? Would you like to try to think of how you would manage the patient?
Because patient come with the symptomatic anemia with the compensated shock. This child need the initial shock management, which is the boluses with normal saline boluses, up to 20 ml per kilo normal salines, and then subsequently might need the packed cell transfusions to normalize the HP. Because of the instance of infections we not could rule out, then the antibiotics, broad spectrum antibiotics will need to be given until proven there is no any infections going on. The second thing is to take all the, before the transfusion, take all the nutritional, like baby 12, folate, to see for definite deficiency for this patient, and then to see for the LVP, to see for the true picture of this patient problems before that we transfuse. And then that is actually supportive when we know the patients having B12 and iron deficiency anemia. Then we give the supportive treatment B12 for this child as a B12 deficiency. We give B12 supplements, also iron supplement, maltopher, and then subsequently we do need to follow up further on. Then genetic testing if there's persistent of the problems with the B12. Yeah.
Okay, that's good. So as you rightly mentioned, initial stabilization, so fluid bolus as needed, packed cell transfusion, small aliquots of it, because we don't know how long the anemia has been. It could be chronic, and obviously you cover for presumed sepsis until you get your results. So as you rightly did, and was done for this patient. The LFT and the LDH was gradually monitored, and there was a gradual improving trend on its own. Iron deficiency-wise was started on oral supplements, and for the vitamin B12 deficiency, as you mentioned, was started on replacement therapy. And this child was offered genetic testing, but has so far declined genetic testing. So as you can see here, the FBC shows the response to the vitamin B12 replacement. This is day 1 and day 8 of starting vitamin B12, not day 1 of admission. So day 1 of starting vitamin B12 was about 2 to 3 days before discharge. So there were no more transfusions in between. And day 8 was actually during the first follow-up in clinic. This child was initially started on daily subcut cobalamin, 500 mic. And as you can see from the full blood count, there was actually very good response to this, with improvement in the hemoglobin, the white cell count, very, very drastic improvement of the platelet, and the neutrophil count, and you can see very good reticulocyte response, right? From initial reticulocytopenia to very good response, suggesting that this the underlying issue was the vitamin B12 deficiency causing pancytopenia. All right? Okay. So this is the latest progress of the patient. So this latest investigation taken 3 years later, early this year. The patient's weight is now 60.2 kilos. The patient is about 15 years old. height of 152, and the BMI has actually gone up very nicely. So the appetite has improved, and she's eating all kinds of foods now. The latest FBC is actually shows anemia. Okay, the child is not on iron supplements. It was actually stopped since discharge. So just on her diet. Okay, and perhaps at this point, I carry on. Okay, so this is the blood film, and it shows hypochromic microcytic cells with anisopoikilocytosis, some elliptocytes, and few hypersegmented neutrophils. Vitamin B12 is within normal levels. So there is still some persistence of iron deficiency, but this child is not on supplements, but is on good dietary intake. So seems like the dietary alone is not sufficient, and she's been started on iron supplements. So we are yet to see her response or whether she has refractory iron deficiency anemia. All right. So we had sent off the antiparietal cell antibody and the anti-intrinsic factor antibodies. The antiparietal cell antibody came back positive. Do you know any definitive terms for this? Or type of anemia that we would call this?
For the parietal cell antibody.
Yeah. So it's known as pernicious anemia. Okay, pernicious anemia, which is basically an autoimmune cause for the vitamin B12 deficiency. And it is a manifestation of late-stage autoimmune atrophic gastritis.
Okay, I guess,
One more
your
slide.
final diagnosis?
So the final diagnosis for this patient is autoimmune gastritis with pernicious anemia and iron deficiency anemia, and the pancytopenia was secondary to pernicious anemia.
Okay, I guess that's conclude the case presentation. First of all, I'd like to congratulate Dr. Rizwan to really get to the case in terms of the vitamin B12 and folate. And as you can see, they are more than just what it is. They are actually an underlying cause of it. And again, I'd like to thank Dr. Rizwan for that. And then, of course, Dr. LEELA and Dr. AZLIN. But I believe you can sit down, Dr. Rizwan. I believe Dr. LEELA have some learning outcomes and points that she wants to share with the crowds on autoimmune gastritis. And I hope that, you can do that within the next 5 minutes.
Okay. All right, so I'll just talk a little bit about autoimmune gastritis with pernicious anemia. Okay, so autoimmune gastritis is basically an organ-specific autoimmune chronic inflammatory disorder which affects the corpus fundus gastric mucosa and it leads to progressive mucosal atrophy. So this is actually mainly described in adults and presenting with pernicious anemia. And usually they present in middle age, between 50 to 70 years of age. And there's a female predominance, as is seen in most autoimmune diseases with a ratio of 2:1. So it is actually very rare to see this in children. So the main autoantigen here is the gastric protopump, which is located on the parietal cells. So what happens is autoreactive T cells would recognize this autoantigen and stimulate B cells to produce anti-parietal cell antibodies, which is actually the serological hallmark for this. But to a lesser extent, sometimes you might find anti-intrinsic factor antibodies to be positive. It is not known to be genetically inherited, but it does occur in genetically predisposed individuals. So to understand it a little bit better, we need to sort of understand the anatomy of the stomach. So I'll just go through just very quickly. So as you can see, this is the esophagus, and this is the gastroesophageal junction. Just below that is the cardia, and this is the superior dome of the stomach, which is the fundus, which then becomes the body or the corpus of the stomach. Okay, and then from there it forms the antrum, which is bordered by a sharp angle here, which is the incisura angularis. The antrum is the prepyloric region, which contains mucosecreting glands, and this is the pylorus, which is the entrance to the duodenum, the first part of the duodenum. So it's actually divided phenotypically and functionally into two separate segments. So the first segment here is actually contains oxyntic mucosa, which occupies the cranial 2/3 of the stomach, which involves the fundus as well as the corpus. And then you have the distal mucosecreting mucosa, which involves or occupies the antrum. And this area has the G cells which produce gastrin. So the main issue in autoimmune gastritis, as mentioned earlier, is actually at the parietal cell, also known as the oxyntic cell, because it's located in the oxyntic mucosa only. And this is where you get the proton pump, gastric proton pump, as I mentioned earlier, okay, which usually releases hydrochloric acid and intrinsic factor. So what happens in autoimmune gastritis is you get autoreactive T cell which recognize this antigen and stimulates B cells to produce anti-parietal cell antibodies against this proton pump. So it causes inhibition, and therefore you get inhibition of production of acid. So the hydrochloric acid is essential to convert ferric to ferrous, which is the absorbable form of iron. Okay, and the intrinsic factor, as Dr. Rizwan had correctly mentioned, is required for vitamin B12 absorption. So it forms a complex with vitamin B12, which is the cobalamin intrinsic factor complex. And this is absorbed via receptor-mediated endocytosis at the terminal ileum. Okay? So this just illustrates what I had just mentioned, the fundus. So two phenotypically distinct compartments, and parietal cells produce acid and intrinsic factor required for iron absorption and B12 absorption, without which you can get these dual nutritional deficiencies. Okay? This just shows what you might see endoscopically. So the part of the body of the stomach, you can see atrophy with sparing of the antral region. So clinical course in autoimmune gastritis, early on, you will get hypochlorhydria or achlorhydria. And most patients, especially in children, they present with, they're either asymptomatic or they present with refractory iron deficiency anemia. But over time, you get chronic inflammation and atrophy of the oxyntic mucosa. So as mentioned earlier, liver stores of vitamin B12 can last for years, up to 10 to 12 years. So pernicious, when they present with pernicious anemia, it's actually a late stage manifestation of autoimmune gastritis when the stores are depleted. So what are some of the long-term complications that might arise? So you might get refractory iron deficiency anemia. So if there's extensive atrophy of the gastric mucosa, then iron will not be able to be absorbed, even with oral supplementation. And then pernicious anemia we talk about. So vitamin B12 is important in DNA synthesis. So it's important especially in rapidly dividing cells in the bone marrow. So you can get ineffective hematopoiesis. And that's why you might get pancytopenia and megaloblastic anemia. It's also important for neurological functions. So patients may present with peripheral neuropathy, and in adults, they actually present with neuropsychiatric symptoms as well. And the hemolysis, the intramedullary hemolysis that we saw, so biochemically you see hemolysis, but peripheral blood film has no signs of intravascular hemolysis because of these defective cells that are being made that releases the LDH and maybe cause a bit of unconjugated bilirubinemia as well. So over time, longer term, because of this chronic inflammation, you can get intestinal metaplasia, and there's high risk for gastric adenocarcinoma, as well as type 1 gastric neuroendocrine tumors. So they will need regular endoscopic surveillance for this. So this just goes to show why you might get these neuroendocrine tumors. So when there's reduced acid, you get a negative feedback, so it activates your G cells to produce gastrin, and the gastrin will then stimulate the enterochromaffin-like cells to release histamine and try to stimulate more acid production. So, which we know it will not produce because it's atrophied, and consistent stimulation of these ECL cells will lead to possible neuroendocrine tumors developing. So there's very little I can find about juvenile pernicious anemia. Most of it are case reports or case series. So no obvious genetic inheritance that has been found. This is a very old paper that just looked at children or juvenile pernicious anemia, and they found that there were two groups. One which actually lacked intrinsic factor, but had normal acid secretion, normal mucosa, and antibodies were not found in these patients. So they were just producing, they were not producing enough intrinsic factor, probably by genetic reasons. And the second group, similar to our patient, had achloridria and antibodies to parietal cells were actually detected in these patients. And this group of patients had associated endocrinopathy. So our patient were only screened for thyroid, which was normal, then we did not screen for other endocrinopathies as yet. So management will be lifelong cobalamin injection and iron replacement. The patient, as you rightly mentioned, will need regular clinical and biochemical monitoring of the micronutrient deficiencies. And the patient will need an upper endoscopy to confirm the diagnosis and test for H. pylori as well, because H. pylori is the other potential cause of atrophic gastritis. So you don't want a double hit to increase the child's risk of getting lineoplastic complications. And regular endoscopic surveillance for early detection, as well as genetic testing for this patient, especially in view of the early onset and strong family history. So what are the case learning points from this case? We should always consider pernicious anemia as a cause of pancytopenia, even if the peripheral blood film is not the classical megaloblastic picture. Autoimmune gastritis can cause dual nutritional deficiencies. Management of pernicious anemia is lifelong IMO succut injection. And we need to consider endoscopic surveillance for intestinal metaplasia, as well as gastric neuroendocrine tumors, based on the initial endoscopic histological findings. Juvenile pernicious anemia in the context of a positive family history may suggest a genetic predisposition, which warrants genetic testing. Here are my references. Yeah, that's all.
So thank you so much, Dr. LEELA. For the sake of time, we are not able to have a Q&A session. But again, I would like to thank the three speakers, Dr. Rizwan, for directly dissecting the case, Dr. LEELA for elucidating the case very nicely, and Dr. AZLIN to basically help us to look at the full blood picture. For the student, we have Kahoot for you all after this. I think there's a question that will be prepared by Dr. LEELA. But I hope the case was started with a hematological state, eventually leads you to unravel to the other specialties, particularly with Dr. LEELA as a gastroenterologist and myself as an immunological consultant. And hopefully, we are not going to go to the oncology if we do a proper surveillance. So do think about multidisciplinary, do think beyond the box when it comes to this case. And every child is not a textbook. So as you can see, the reason why Dr. Rizwan did not think about did not think about vitamin B12 is because he was looking at megaloblastic. When it comes to the actual case, it is quite rarely we actually see a megaloblastic picture in the case of a vitamin B12 where iron deficiency anemia is a concurrent symptom. Thank you so much. Yes, Prof. Chia, yeah. The liver, yes. Yeah.
It's not known to be associated with the liver, so we think it's probably just with the intercurrent illness. She probably came in with some viral hepatitis, came in with fever, and hepatitis, which actually improved very quickly on its own, just suggestive of. Yeah, there was follow-up, it normalized eventually.
Even during the admission, it normalized within 2 to 3 days. Yeah. Okay. Thank you so much. And for the student, there's a Kahoot for you all. Thank you for joining the CPC today. Thanks.